Hi, I'm Aaron Sodikson from Brigham and Women's Hospital. I'll be speaking today about how to make your scanner sing using the equipment you have for high quality at low radiation dose. I like to think about risk from CT scans as a drop in the bucket. Any individual exposure imparts rather small risk to the patient, but to understand this better, we need to know how large is this bucket of risk, how full is it at baseline, and how quickly are we adding to it, because we have certain historical experiences that single exposures, if large enough, can impart substantial risk. We also need to know how rapidly we're adding to this bucket of risk in terms of how often we're imaging our patients. This lends itself to a couple of different ideas about how we can intervene to control radiation exposure. We can work to control the drip rate, or we can work to reduce the drop size. And this, of course, depends on where in the imaging chain we intervene. Before the scan, there are many opportunities to reduce our drip rate. This is where we have the chance to control utilization by designing imaging algorithms, ideally based on good evidence. We can make decision support interventions, and we can consider use of non-ionizing alternatives. Others in this symposium will focus more on this part of the imaging chain and potential interventions. For this talk, I'll mostly be focusing on what we can do during the scan, how we can reduce the drop size, and really the task here is to figure out how to dose optimize our protocols to find the sweet spot between the lowest exposure appropriate for a given clinical scenario while still producing robust diagnostic quality scans every time. After the scan, there's a lot of opportunity to capture patient and exam-specific exposure information, ideally to convert this into meaningful measures of patient dose, and to do longitudinal dose and risk monitoring in the electronic medical record. And I'll focus a short talk in session 9 on these two portions. Before we can move on to talking about scan optimization, we need to understand a little bit about the common X-ray tube output metrics used in CT, the volume CT dose index, and the dose length product. Very important to understand that these do not represent patient dose, though with some assumptions they're often used to estimate dose to patient, with CTDI vol used to approximate organ dose to the patient, and DLP used to create some estimates of overall effective dose to the patient. So just to describe briefly what these are measures made by a medical physicist when calibrating a CT device. They're made in a standard 32 centimeter body phantom or a 16 centimeter head phantom, as you can see here. And what happens is a medical physicist will place an ionization chamber in either the central or the peripheral hole of one of these acrylic phantoms, expose it to a certain CT technique, and then the CTDI vol is simply the weighted sum of these measurements with a geometric conversion factor to correct for the pitch of a helical scan. Dose length product then takes the CTDI vol and multiplies by the exposed length of the patient from head to foot. So when looking at actual organ doses to patient, these are Monte Carlo simulation results done by the UCLA group. What you see here is organ dose for a fixed CTDI vol. These are the organ doses to patients of different sizes. And as you can see, for the same technique, we have substantially higher organ doses to small patients and lower organ doses to large patients. This is due to internal shielding effects. Essentially, these large patients are shielding their radiation-sensitive central organs from the incident X-rays. And this is an important relationship to understand. So as I just showed you, for a given CTDI vol, organ dose decreases as patient size increases. At the same time, tube current modulation, which I'll describe in more detail next, increases the CTDI vol as patient size increases in order to maintain the desired level of image quality that we're after. And if you take these two effects together, we find that in general, large patients do receive higher doses than small patients, but not nearly to the degree we might expect if we were purely looking at the raw CTDI vol values themselves. Now, the next trick that people will often use in thinking about patient dose is they'll take dose length product and they'll use one of these K factors or conversion factors, which were derived a long time ago from Monte Carlo simulation studies. So the way this is done, here's a dose screen from a patient getting a multi-part scan in trauma. And what would be done is you would take the DLP of a particular scan part, multiply by the corresponding K factor, and you would get an approximate effective dose that that patient received. This technique is reasonable for approximation, but it has a lot of limitations. The main ones being the same as I discussed on the last slide, that this technique overestimates radiation dose for large patients, underestimates dose for small patients, and there's a lot of uncertainty in these numbers because these K factors were derived as population averages across patients of all different sizes and genders. That said, these metrics are very important ones to look at and to understand, and I encourage all radiologists to review these numbers on PACS, because this is the way you gain familiarity with typical values and with how these values might change with patient size. This makes it possible to identify outliers. It's important for quality control efforts, and it's helpful in understanding where your scan performance is relative to diagnostic reference levels, such as those required for ACR accreditation. I'm now going to talk about several general strategies that can be used to reduce drop size, to reduce radiation dose, ideally without harming our diagnostic confidence in looking at these studies. The first general strategy is to use size-dependent protocols. I like this image. This is taken from the Image Gently campaign, and the point is that this well-designed device really only has its intended benefit to the patient if it's appropriately sized to the patient. If we don't size it appropriately, we can actually not only eliminate the potential benefits of the device, but we can actually create potential harm. We want to avoid doing this. Now, one of the best ways to do this is to use the tools that we receive from the manufacturers. And this slide shows tube current modulation, or automatic exposure control. And this is a general category of techniques that are actually rather robust on almost all the scanners in use today, where we can adjust the CT scan technique to the size of the patient. What you see here is in green on the left axis is the relative tube current that the machine uses, and on the right in red is relative image noise. And as you can see here, the scanner has adjusted our imaging technique, has adjusted our tube current in order to maintain a relatively constant level of image noise across the entire patient. The scanner looks at the patient from a scout planning projection radiograph, and it identifies areas of lower and higher attenuation. And as you can see here from the solid green line, the scanner can get away with using far less tube current, far less X-rays sent at the patient in areas of low attenuation like the lungs, where there's very little tissue that needs to be penetrated. On the other hand, in areas like the shoulders, like the abdomen or pelvis, we need more X-ray tube output in order to produce the desired level of image quality. Now, that's longitudinal tube current modulation from head to foot, looking at gross variations in attenuation along the z-axis. But the next thing that we have here on this slide is in-plane or XY axial tube current modulation, and that's these light oscillating curves here, where you can see in the shoulders, for example, we need much more X-ray tube output in a lateral projection through the shoulders than we do in a frontal projection, which is much narrower with much less tissue to penetrate. Now, here's an example of how tube current modulation has gone wrong, which helps, I think, to understand how it works. We did this scout projection radiograph in this patient with the diaphragm located where you see it. Since this scout was taken, the patient somehow shimmied north, and so that at the time the CT scan was actually performed, the diaphragm was much higher. Nonetheless, the scanner has no way of knowing this. The scanner assumes that the lung remains where it was on our scout view and scans the patient with an X-ray tube output appropriate for the lung, which is simply not enough to get high-quality imaging through the liver. So as a result, you see more noise in the top portion of the liver and less in the bottom of the scan. Approaches to tube current modulation, and it's really important to spend some time understanding how your scanner does this technique, because there are many parameters that come into play that you need to understand to do this right. The first general approach is the noise index approach. This is generally what's used on GE and Toshiba scanners, and in this approach, the scanner is configured to try to preserve an equivalent level of noise across patients of all different sizes, or body regions of all different sizes. Now that only happens to a point that we max out and we min out at the maximum and minimum MAS that we either configure on the scanner, or that's an inherent engineering limit of how many X-ray, how much MAS the tube can actually create. We can adjust these curves with the noise index. On the right, you have a high noise index scan where we are permitting more noise in our images. This means lower dose technique to the patient. Whereas towards the top, we've used a low noise index where we've told the scanner we want images with less noise, and as a consequence, we're giving higher radiation exposure to the patient. Now the next general strategy to tube current modulation is the reference MAS approach, and this is what's used by Siemens and what underlies the techniques on the Philips scanners as well. In this technique, the users set a quality reference MAS that tells the scanner what's the image quality that we want for patient of a specific size, the patient with the reference attenuation, roughly that of a 70-75 kilogram patient. The scanner then recognizes from the scout that our patient is either smaller or larger than this reference attenuation, and it ramps the MAS up or down accordingly to maintain the desired level of image quality. Now you can see that compared with the equal noise approach, we actually fall off that curve. We're actually allowing, in this technique, we're allowing more image noise in our larger patients because we have fat to help us surrounding our internal organs. Whereas for slim, smaller patients, we produce images with higher quality, correspondingly somewhat higher radiation exposure than we would with the equal noise approach. Now some of the scanners are configured so that we can adjust the strength of these modulation curves for small and large patients. I should mention here that if we want to change the overall level of our image quality, akin to changing the noise index in the other method, we simply raise or lower our reference MAS in this approach. Here's an example of this, of tube current modulation at play. Here we have two different patients, clearly of very different sizes. And we're producing scans here with identical technique, the only difference being the phase of IV contrast timing for this PE versus dissection study. But you notice by looking at the soft tissues that the amount of image noise we're looking at here is quite comparable between the two patients. In order to accomplish that, if you look at the MAS or the CTDI vol values, you see that in the patient on the right, the larger patient, we needed almost 2.5 times as much X-ray tube output as we did for the smaller patient. And while this sounds like a much larger dose in this large patient, this is required variation in our technique needed to maintain the desired level of image quality. Here's what it looks like in a larger group of patients. This is a number of PECTs. Let's focus on the blue dots at the moment, which were performed at 120 kV. And you can see here the expected increase in CTDI as patient size increases in order to maintain image quality as we'd like it. Now the next general strategy I want to talk about is in thinking about your protocols, it's important to examine the value of each pass we take through the patient's anatomy. Here's an example, a routine abdomen pelvis CT. It became fairly popular several years ago since we were giving IV contrast to try to extract as much information as possible by doing a delayed scan through the kidneys and through the bladder. But I would argue that this actually adds a substantial additional dose while providing very little clinical yield, at least for the patient population of routine abdominal CT for abdominal pain. As you can see by looking at the DLP down on this dose screen, these additional delayed phases adds about 60% of additional radiation exposure to our scan, and it's a very rare patient where we actually find something of clinical benefit in these additional scans. It's also important to think about whether we need all of the phases in our multi-phase scans. Here are several examples that are traditionally 3-pass scans. In certain circumstances, we don't always need all of these phases, and we can spare the patient the additional radiation from one of these passes. And I'll give an example in dissection CT in a moment. The other thing to think about is, can you combine any of the phases? There have been many groups recently using a split bolus technique for CT urography, where some of the IV contrast is given initially, allowed to get into a pylographic or excretory phase, and then the remainder of the contrast is given for a combined nephrographic and pylographic phase scan. Dual energy CT is another area where we're seeing more of this possibility, where we don't actually perform a true non-contrast scan, but we can recover it after the fact in a virtual non-contrast scan with no additional radiation dose penalty. Here's an example of dissection CT. We addressed this several years ago because in the ER we found that this was one of our highest dose CT scans, but in our population this was actually a screening exam with a positive rate of actual acute aortic dissection of only 1 to 2%. At the same time, we found that of those scans that were positive, very few had isolated intramural hematoma requiring that non-contrast scan. And in all of our patients, they tended to be tachycardic patients where cardiac gating really didn't work terribly well without heart rate control. Here's what we used to do. We used to do our non-contrast chest scan looking for intramural hematoma, followed by a cardiac gated CTA of the chest, followed by a delayed scan of the chest, abdomen, pelvis, making sure we captured the entire extent of the aortic dissection if it was present. We changed this approach to a single pass, non-gated chest CTA. And as you can see from these two patients, considered to be of comparable size by the scanner, this results in almost an 80% reduction in overall DLP, purely by virtue of removing those additional passes through the patient. Here's our general algorithm. We do still have our full protocol for patients who come in with a high pretest probability of disease, such as those following up a known dissection or maybe a patient with Marfan syndrome. But the vast majority of our patients are screened with this single pass protocol. We find a normal aorta, dissection absent, and we're done imaging. Now there are still some other rare occurrences. If we find a dissection, we need to image the full extent. So in our place, we actually have these monitored live by our radiologist who makes an instantaneous decision about whether to continue scanning through the entire abdomen pelvis. But in other places that can't monitor their scans like this, you might just extend through as a single pass through the abdomen as well. And then we have a few indeterminate cases, or cases that need troubleshooting. The one that concerns most radiologists whenever I mention this is the concern about missing isolated intramural hematoma if we don't actually have a dissection flap. So here's what we see. We see this crescentic rim of soft tissue along the wall of the aorta. Is this intramural hematoma? Is this chronic atherosclerotic plaque? The solution when these rare cases occur is to keep the patient on the scanner. It usually actually only takes 5 or 10 minutes to clear the contrast out of the blood pool. And you can see now this IMH appears dense compared to the unenhanced blood pool. And so it's okay to bring back an occasional patient. I'd rather bring back or do delayed imaging on 1 in 200-300 patients than do shotgun imaging for all of our patients that expose. Here's another general strategy to think about. When we're planning multi-part scans, think about the overlap between the different scan parts. This is a trauma patient getting scanned from head through pelvis, and as you can see, we have substantial overlap between our head and cervical spine scan, between our cervical spine and our chest scan, and the greatest area of overlap between our chest and abdomen pelvis scan, because most of our technologists have been trained to scan the chest all the way through the adrenal glands and to make sure we have some buffer above the diaphragm when we're scanning the abdomen pelvis. Well, with some thought and deciding what our priorities are on these imaging, we can really cut down substantially on these areas of overlap, potentially even scanning adjacent body parts in a single pass, depending on the clinical need. The next general strategy is to reduce MAS, or tube current, whenever possible. And it's important to realize that dose requirements depend on the task, the clinical task at hand. When we have inherently high contrast structures we're trying to visualize, we can really do this while allowing a lot more image noise and as a result, less radiation dose. And some common examples of this I show here. Lung scans, where we're trying to find lung nodules, for example, on the background of aerated lung, can be performed with very noisy scans because we have inherently high contrast between the target lesion and the background. CT angiography can be done if we spend our time really optimizing our enhancement of the vascular bed of interest. And ureter CT has been an often studied example of how we can do low-dose imaging without hampering our ability to detect ureteral stones. The caveat being that I think we need to make sure that we're doing these scans purely to find ureteral stones, and when we're looking for alternate diagnoses, we need to tailor our scan towards the entire clinical question. So one approach that I've found very helpful here is to reduce MAS incrementally until we find our comfort zone of the image quality we need for the diagnostic task. And it's important to include your stakeholders here, the other radiologists in your group, because people have different levels of comfort and people can gradually acclimate to lower dose, noisier images. The next general strategy to think about is to optimize IV contrast infusions. As I mentioned in the last slide for CT angiography, if we can optimize our vascular enhancement, this increases the contrast to noise ratio of what we're trying to look for. And if we do that well, we can actually turn around and lower the technique that we use to acquire those images. Optimizing our IV contrast infusions also has the benefits of reducing the rate of non-diagnostic scans and reducing the need to repeat scans, which of course imparts additional radiation exposure. And this paper I highlight here is an excellent review of some of the principles of IV contrast kinetics that are useful in protocol optimization. Here's one example of a change we made several years ago to our PECTs. We had initially been giving this larger dose of contrast, 125 ml at a slow flow rate. When we got rid of the lower extremity venograms we were doing with these PECTs, we reduced to 75 ml of contrast at a higher flow rate. And as you can see from the data points at left showing the pulmonary arterial enhancement, and from the simulations at right, this really was a lateral move. It didn't really have an overall impact in improving the quality of our scans. But by going to an even higher flow rate, you can see that on the green data points here that we have a substantial improvement in our pulmonary arterial enhancement accomplished just by better timing our scan to our IV contrast infusion. The next general strategy that's particularly helpful for CT angiography is to use reduced kilovoltage of our scans. As you can see from this phantom experiment on the right, we have a bag of saline in the center, flanked by 2 bags of saline with a little bit of iodine in them. And as you move down towards lower kV scanning, you can see that for the same concentration of iodine, you actually achieve more enhancement at lower kV. And this is shown graphically at the left here, where compared to imaging at 120 kV, we see a 27% increase in our Hounsfield units at 100 kV and a 74% increase on this scanner at 80 kV. At the same time, if we leave our MAS unchanged, we see reduced dose at these lower kVp values. And if you look at a curve like this, you think, well, I go to lower kV, I achieve higher levels of enhancement at lower dose. This is a win-win. Why wouldn't I do this in everyone? And the answer is that it's great for patients who are small enough, but it is not appropriate to do this for very large patients because our result ends up being a very, very noisy image. And even though we have better enhancement, we lose our ability to make a confident diagnosis. So here's an example of this approach in PECT. These 2 patients are considered by the scanner to be of essentially equivalent attenuation. You can see the result down below. On the right, the 100 kV scan does show a little bit more image noise in the soft tissues, but the diagnostic quality for pulmonary embolus is fantastic in both of these cases. And if we look at these CTDI vol values, we find roughly a 40% reduction in radiation dose at 100 kV, despite the fact that we've also actually reduced our IV contrast volume by 1/3. So this is the approach we've adopted for some time now. We have a rough threshold of 175 pounds. Above this, we scan at 120 kV with a larger 75 ml IV contrast bolus at a higher flow rate. For smaller patients, we scan at 100 kV with a 1/3 less IV contrast at a slower flow rate to match the duration of the scan. And what we found is that we see preserved diagnostic quality despite the fact that we're simultaneously reducing IV contrast and radiation exposure by 33% in these 100 kVp scans. Here's that data that I showed a little bit earlier, but now you can look at the red dots, which are the scans at 100 kV, and you see that in patients that are small enough here, we see that 33% overall dose reduction from using this technique. One caveat I'll mention, the cause of remaining non-diagnostic scans, even after you've optimized these infusion parameters, is Valsalva effect. And here you see it. You've got good contrast still coming down the IVC, but this is met by a slug of unopacified blood from the IVC. This occurs really because the patient takes a deep breath in and holds it, lowering their intrathoracic pressure, while simultaneously bearing down, raising intra-abdominal pressure and forcing that unopacified blood up into the heart, where it mixes with perfect timing to wash out the pulmonary arteries and ruin our scan. The solution when this occurs is to simply repeat the scan in expiration. This reverses the physiology I mentioned. It increases pressure in the chest. It's harder to bear down when you have an expiratory breath hold. And this almost always fixes this Valsalva effect and is one of the additional benefits of giving a lower volume of contrast, particularly in our smaller patients. I won't go through this in detail, but I wanted this slide here really for syllabus purposes. For anyone interested in trying to optimize your IV contrast infusions, this is what we do. And you'll find, if you want to try it, that it works out very well for scan durations less than 9-10 seconds or so if your scanner is fast enough. The last general strategy I'll mention is to use noise-reducing reconstruction techniques. The main principle here is that anything we can do to reduce noise in our post-processing allows us to turn around and lower our parameters and do lower dose acquisitions up front. So one example of what you can do is to reconstruct thicker images. 4 millimeter images are created by 4 times as many X-rays as 1 millimeter images. And as a result, they have half as much noise as those thinner images. This is a good technique to salvage scans, noisy scans, for example, in very large patients. The other thing you can do, you can certainly always use a smoother reconstruction algorithm. We're familiar with what this looks like from the difference between soft tissue and lung algorithm reconstructions. The trade-off, of course, as we all know, is the loss of edge detail information, but another useful technique if we're trying to lower dose. And finally, there's been a lot of discussion recently about iterative reconstruction or other noise-reducing post-processing techniques. The general principle here is our scanner acquires our raw data projections. It normally does our filtered back projection to create our axial images, but in iterative reconstruction, we can actually forward project these images to create simulated raw data projections. We can see how these differ from the actual measured projections and do some correction steps. Now, this can be a computationally intensive and time-consuming process. So all of the different manufacturers have different variants of iterative reconstruction and have taken different algorithmic shortcuts to speed this process up. But the end result is that these techniques can reduce noise or can reduce artifacts or both. The caveat is that they do create different noise textures, and so radiologists often need some time to acclimate to the different image appearance in order to find that comfort zone for the diagnostic task at hand. I've tried to step through a bunch of general strategies that can be very helpful in thinking about how we reduce dose to our patients in CT. With that, I think we'll have a question and answer period remotely in a moment, and I'd like to thank you for your attention.